Now we're going to move to our last topic. We've discussed a number of ways of identifying patients that are at risk for anticoagulant-associated bleeding. We've talked about how to handle that bleeding, but of course prevention is the best course, and there are strategies for actually helping our patients and shepherd them through a course of anticoagulation and minimizing the bleeding risk. And Katelyn Sylvester works very closely with all of us in helping to lead the effort on our anticoagulation management service, and she's going to speak to us about an ounce of prevention, strategies for safe anticoagulation in vulnerable patients. Katelyn, thank you.
Thank you, Dr. Piazza. Thank you guys all for sticking with me till the very end on a weeknight after a long work day. So I'm going to actually hit on a lot of the topics that were already covered and try to put them all together in summary for the end of the night and talk about how Dr. Ruff mentioned that the most important thing is prevention. So we really don't want to get to the treatment of the acute bleed. We want to do the best we can to prevent it. Here are my conflicts of interest. You will note that my biggest conflict of interest, however, is that I am the manager of the Anticoagulation Management Service, so there are some great plugs in here for having your patients managed by a centralized anticoag clinic. We're going to review different strategies to prevent or minimize the risk of bleeding for patients on anticoagulation, and then describe the roles and benefits of a centralized anticoagulation management service, both for those patients traditionally on warfarin, we think of the Coumadin clinic, as well as the expansion to full-service anticoagulation management services that also cover the direct oral anticoagulants. So here's sort of an outline for the presentation as well as some easy steps to keep in mind. So first, you want to identify patients at increased risk of bleeding, and Dr. Ruff already went over some of the risk scores that can be utilized, and we'll review those quickly again. After using the risk scores, you'll be able to identify some of the modifiable and non-modifiable risk scores, and you want to do the best you can to adjust the modifiable risk factors to eliminate that additional bleeding risk. Using patients as their own advocates is a very important way to minimize the effects of bleeding. So really counseling patients not only on their initial visit or their initial prescription to an oral anticoagulant, but continuously throughout their entire course of treatment. Talking to them about the importance of adherence, and we'll talk about that. So, a lot of the trials you were looking at adherence rate of 80%, real-world trials are 40 to 60%, and what does that do to outcomes? Talking to patients about the signs and symptoms of bleeding, and we'll talk about why nuisance bleeding, although may not present to the emergency department, does have a profound effect on patients' treatment because it leads to patient self-discontinuation. And then also, things that patients may not want to talk about is modification of high-risk lifestyles, so we'll talk about that. As a practitioner, you want to think about choosing the best anticoagulant for your patient, which is going to include a whole host of things like patient characteristics, end organ function, things that are important to the patient, what insurance they have, what does coverage look like, so looking at the entire scope. You want to make sure that patients are dosed appropriately initially. So again, some of the previous practitioners have mentioned that there's inappropriate initial prescribing, using lower doses because you're afraid of bleeding, or using VTE doses for AFib. And then you want to also consider your ongoing dose adjustments. At what time is it appropriate to discontinue therapy or de-escalate therapy? And then thinking about all of the procedures that do come up, you saw that 10% of patients have a procedure scheduled, which is either planned or unplanned, and you want to think about how you can mitigate the risk during that time period. Oh, I forgot the most important one, and you want to optimize care by enrolling your patients in a centralized anticoagulation management service if you have access to that. So for the bleeding risk assessment tools, there are a lot of them now out there, and you want to consider a couple things when deciding which tool to use or potentially even using a combination of tools. So you want to think about what patient population the risk assessment tool was validated in. So you can see at the bottom, some were validated in atrial fibrillation patients, while others looked at venous thromboembolism. Do you have the availability of all the components of the test score? So we heard that the ABC bleeding risk score may be more sensitive and specific for bleeding versus thrombosis risk factors, but do you have access to all of those biomarkers? And how complex is the tool to use in your clinical practice when you're seeing many patients back-to-back during a visit? And then you also want to consider, were these tools validated only in vitamin K antagonists, which the majority of them were, or can they also be used with patients on direct oral anticoagulants? So overall, you're going to take the data from these tools as well as the clinical picture and try to determine what the risk is of thromboembolism versus the risks of bleeding and determine what's most appropriate for your patient in a systematic manner. I think when we're talking about your old patients, your frail, your elderly, there's that gut reaction of what's clinically appropriate, and then there's using a systematic tool and looking at the data. And then again, we want to identify and potentially minimize the modifiable risk factors. So here are the risk factors sort of all put together from all of the different tools, and you can see on the left side what the risk factors are, and on the right side which tool they're part of, and they're all data-driven and externally validated. So on the left, there's all your modifiable risk factors. These are the things that you can talk to the patient about, you can potentially eliminate and or mitigate. So for hypertension, we're talking about patients with a systolic blood pressure of greater than 160. So you want to use guideline-based treatment. For most patients, the optimal blood pressure is less than 130 over 80. And so you want to get patients to that goal to try to mitigate. This is both a risk factor for bleeding and thrombosis. For patients on warfarin, we know that not only having a low time in therapeutic range, but even more importantly, having that labile time in therapeutic range really is an adverse effect for the patient. So in those patients, you want to think about, why does this patient have a labile INR? Are they appropriate candidate to be transitioned to a DOAC? So for atrial fibrillation and VTE, most patients can be transitioned over to a DOAC as long as they don't have patient preferences or insurance barriers. But for your patients who warfarin is the optimal choice, think about, can they not get to a lab to get their INR? Can you do home monitoring? Do you need face-to-face visits? Do you need to do additional phone calls to improve adherence? What can you do as a provider to really optimize the only agent available for this patient? Thinking about other medications that increase the risk of bleeding, multiple practitioners have already talked about the aspirin epidemic, so we have tons of patients who are put on aspirin for primary prevention. Really, data no longer supports that. Or patients who were initially put on aspirin because of a stent placement 10 years ago and may not still need that aspirin on board. So really continuously analyzing your patients to make sure they're optimized, and then talking to them about excessive alcohol drinking. Then some potentially modifiable risk factors are anemia, impaired renal function, impaired liver function, as well as both platelet count and function. And then we move over to the non-modifiable risk factors. It's important to understand what they are and when you're thinking about your global risk assessment, but there's nothing really you're going to do about those. Those are age, history of bleeding, history of stroke, end-stage renal or liver disease, malignancy or genetic factors. And then we have to consider also the biomarkers that Dr. Ruff already talked about. Already went into a lot of detail on this fall risk in anticoagulation, so I'm not going to belabor the point. But a patient would have to fall many, many times in order for the risk of a fall and a fall-related ICH to outweigh the benefits of anticoagulation. So about 50% of the elderly patients who would be eligible per guidelines for anticoagulation are not appropriately treated. So consider that. I mean, it's kind of the opposite of what I'm talking about of preventing bleeding, but the whole reason for anticoagulation is that we're mitigating the risk of thromboembolic events. So important to keep in mind. Talking about patient education. This is a big thing that we see in the anticoagulation management service. So we have a lot of patients that come to us that were started on anticoagulation potentially in the emergency room. They're started with a copay card. They get their first prescription for their DOAC. They show up for their refill. They need a prior auth. Nobody knew about it. Nobody did it. Patient doesn't really know what that means. They go home, no anticoagulation for 3 or 4 months, show back up to your PCP who assumes they've been taking it, and now we've got to determine what the problem was. So making sure that you follow up after that first dose, have the patient come back to clinic or call the pharmacy, make sure that they've picked up the refill and there were no barriers, and really having that open communication with the patient. Again, addressing the importance of adherence, taking your medication as prescribed, letting you know if there were missed doses, so that you can work with them to try to rectify the situation or talk about different adherence monitoring tools that they could use at home. Discussing signs and symptoms of bleeding. So again, even though nuisance bleeding is something that they don't report to the hospital and they may not even report to you, if they're having frequent nosebleeds, heavy menstruation, they may decide to self-continue the medication, and that can have long-term consequences. So you want to open that dialogue early, talk about what those nuisance bleedings mean, and make sure that they come to you before they make their own decision. Modification of high-risk activities. There's a couple interesting papers out now that have not been validated. They're not in randomized control trials, but with these short-acting direct oral anticoagulants, can you potentially stop them, allow a patient such as a professional athlete to compete in their high-risk activity and then restart anticoagulation? I mean, it's interesting. With calibrated drug levels, you'll be able to really assess the peak and the trough, but we also know that patients are at highest risk of both bleeding and thromboembolism in that period of transition. So something interesting that will probably be studied more, but definitely that risk-benefit analysis where you're having this shared decision-making with the patient. What's important to their lifestyle? What is going to prevent them from taking their anticoagulation as prescribed? And as a team, how can you optimize that? We all know the effect of adherence on outcomes, and so, when the direct oral anticoagulants all came out, we thought, great, we had very poor adherence to warfarin. We're talking about 40% in some of the real-world data. These are just a single pill, you take it, there's no monitoring, adherence should be fantastic. Real-world data has shown, again, somewhere between 40 and 60% adherence. The patients with the CHA2DS2-VASc 2 or greater are really where we're concerned. They get the most benefit for anticoagulation, or the most net clinical benefit, compared to the increased risk of bleeding. And one study showed that for every 10% decrease in adherence, there was an increased risk of all-cause mortality and stroke of 13%. So this, I forgot my pill multiple times a week, really does add up over the course of therapy. When talking about selecting the appropriate oral anticoagulant, this is based on an older publication from ASH, but as more and more data comes out, thinking about updating your own internal guidelines. So when we're thinking about end organ function, if we have severe hemodialysis or end-stage renal disease, really warfarin might be your best choice. There is an approval for apixaban in the package insert, which is based on some limited PK data. There are patients who warfarin is not a choice for in dialysis, who have calciphylaxis, and then maybe this is a good option for you when you're having that shared decision-making conversation. For creatinine clearance greater than 95 in atrial fibrillation, so your patients with great renal function, we know that edoxaban is not indicated based on signals that they saw in the trials. End-stage liver dysfunction, again, we're talking end-stage, not mild liver dysfunction. Warfarin is, again, your best bet. We can monitor the INR. For extremes of body weight, ASH recommends, and this is about BMI greater than 40 or a weight of greater than 120, 150, really sticking with warfarin until we have great data on the peak and trough concentrations of the direct oral anticoagulants. And patients who are less than 60 kilograms, there is dosing information for edoxaban. There's also a dose reduction for apixaban if you have 2 of the 3 criteria in atrial fibrillation. Thinking about drug-drug interactions, there are certainly fewer of them with the direct oral anticoagulants, but there are some where it's a contraindication. In that case, you would go to warfarin where you can monitor the INR. When we're thinking about planned upcoming major surgeries, such as transplant, we only have 2 agents that we should really be using, that we have FDA-approved reversal agents in planned urgent surgery, and that's warfarin and dabigatran. So although Indexanet is available for reversal of apixaban and rivaroxaban, it is approved for life-threatening bleeding, and we don't have a lot of data in using it in surgeries, especially prolonged surgeries and surgeries such as cardiopulmonary bypass, where there's a lot of tissue injury for a prolonged period of time. For patients with a history of GI bleeding or the elderly, potentially warfarin or apixaban. And for patients who you're really concerned with compliance and you think they would do better with a once-a-day med, we're talking about rivaroxaban or edoxaban as your primary agents. Dose adjustments, a lot to think about. What I really want you to think about from this slide is this is not a set it and forget it type of drug, which is how we thought about it maybe 5-10 years ago. You get them on the right dose and you let them go out. Patients are continuously evolving, especially patients who are either elderly, congestive heart failure, CKD, liver disease, active cancer. Their clinical picture is constantly changing, and the most appropriate dose for them may also be changing. So you need to continuously assess the patient and think about, are they on the most appropriate dose? Also, do they even need to still be on anticoagulation? So for patients with atrial fibrillation who haven't had an ablation, we are talking about lifelong anticoagulation. But for your patients who had a DVT, potentially 3 months of therapy is enough in a provoked VTE where the risk factors were removed. If you're talking about unprovoked VTE or risk factors that are still there, after your initial 3 months of therapy, can you de-escalate the dose and use extended duration treatment? So all of those things you want to continually reassess. You want to continually look at, does their benefit of anticoagulation still outweigh their risk of bleeding? Has that shifted the balance? What are the patient preferences now? You want to continue to have that discussion. Do you understand the risks? Do you understand the benefits? Are you okay with this ratio? And what are the goals of care? So if you have a patient with end-of-life care, you want to consider, is the risk of anticoagulation something you want to do right now? Interruption of therapy. Dr. Campia already went over this, but it's just important to know there's a lot of times we have a patient calling into the clinic saying we have a procedure tomorrow that's been planned for months, and I'm still on my full dose anticoagulation, or you have a patient who scheduled for or who comes in for a lung transplant and they're on apixaban, and what do you do about that? So really, again, having those conversations with the patients to communicate back to you, having an open communication with the providers, with the Anticoagulation Management Service or the PCP, whoever's managing that, and say, here's the upcoming procedure, here's what we deem the risk of bleeding is with this procedure, how should we go forward as a multidisciplinary team? And then my biggest plug here is the Centralized Anticoagulation Management Service. A lot of the data on the benefits of an anticoagulation management service are still based on the Warfarin Foundation. I think it's relatively new in the last 5 years that anticoagulation management services were really managing enough DOAC patients to really have data, and there's not as great of a marker like we have the time in therapeutic range. So right now, all of the anticoag services for warfarin are looking at that TTR. We're benchmarking patient against patient. We're benchmarking clinician against clinician, clinic against clinic to make sure we're optimizing care. We don't have a benchmark or standard of care to say, how great are we doing with our direct oral anticoagulants? But we know that having somebody who's specialized, who's focusing only on that area of therapeutics, who's constantly communicating with the patient, who's easy to access, does improve care and mitigate the risk of bleeding. So we'd assume that these would potentially go forward with the direct oral anticoagulants, but here are some of the services that are offered. You want to consider what the model is at your anticoagulation management service and what the scope of the providers are. But in general, they'll deal with initiation and selection of the best oral anticoagulant for the patient, picking the appropriate initial dose and making all dose adjustments as new drugs are added or as new labs values are got. Design peri-procedural management plans, and this is not alone. Usually we're reaching out to the PCP, cardiologist, oncologist, the proceduralist, and facilitating communication between all the groups. Educating and counseling on adherence. We provide generally 24/7 support to triage adverse events. Yes, you need to go to the ED. This is a nuisance bleeding. Here's how you deal with it. Using humidifiers in the winter to prevent nosebleeds, etc. Dealing with all medication refills, prior authorizations, medication procurement, and even better, there's an Anticoagulation Center of Excellence, which provide comprehensive standards for all of the anticoagulation management services. They provide best practices, tools, resources, and they will deem you an Anticoagulation Center of Excellence. Every 2 years you have to reapply, and it allows you to have great access to a lot of data, see what other institutions are doing well, what you might do to improve. Here's just an example of our algorithm that we use for monitoring the direct oral anticoagulants, and you can see that we very systematically evaluate patients and their initial treatment considerations when we're taking them into the clinic. We assess things at every single visit, and how often we assess a patient is determined by how high of risk. We also don't want to be touching these patients as often as we are with warfarin, because that is a benefit of the direct oral anticoagulants. So we want to establish a relationship and then, monitor from afar and provide the assistance that is needed. So we are going to skip the patient case for time and go to the conclusion. So we all know that anticoagulants inherently increase the risk of bleeding. There is a lower risk of major and life-threatening intracranial hemorrhage with the direct oral anticoagulants, but bleeding does still occur. The risk of bleeding can be reduced with a systematic approach to the management of patients on anticoagulants. So some of those include agent selection, dosing based on patient-specific risk factors and indication, ongoing risk assessment and patient education, and addressing any modifiable risk factors that might increase the risk of bleeding. And then enrolling your patient in a centralized anticoagulation management service to provide all of these and ensure that each patient is treated in a systematic fashion and receives ongoing education and monitoring. Thank you.